I welcome you all again to the Flavor of the Month webinar series number 26. The topic of today's webinar is Advances in the Treatment of Macular Edema. The distinguished speaker for the day is Dr. Manoj Khatri in Chennai. He did his master's Sri Ramachandra University, Chennai, and then further he did DNB Ophthalmology from National Board in 2007. He performed his vitreoretinal training at Shankar Chennai. He is also affiliated to esteemed organizations such as All India Ophthalmological Society, Tamil Nadu Ophthalmic Association, Vitreoretinal Society of India, Delhi Ophthalmological Society, and American Academy of Ophthalmology. So we welcome Dr. Manoj.
Thank you so much, Dr. Kumar, and deeply obliged for the kind invitation from the clinical board of Dr. Agarwal's Eye Hospital Group.
And the moderator for today will be Dr. Sunil Ganekal.
Okay, thank you so much once again and for the kind invitation as well. So we will be talking something about on the topic of evidence-based approach in the clinical management of patients with diabetic macular edema. A small request from my side, let this be an interactive session. That means we learn from each other. And also, at any point of time, though it's going to be a lengthy talk about half an hour or so, so at any given time, you have any questions, comments, suggestions, any one of you are most welcome, and stop at that time and we can understand from each other. So with this, let's proceed further as in today's era, what is the current role of management in the in diabetic macular edema? No financial interest in my talk. So first, let's start with diabetes. What is a small overview? So when we look at diabetes per se, it mostly affects working age population. We know that, and it's especially post-COVID era, we are seeing more and more patient in the category of proliferative diabetic retinopathy, and Southeast Asian countries, including India, are not behind in catching up the with American or Latin American population. In fact, we are going to surpass them by 2045. India and China are touted to be as the capital of diabetes, and per se diabetic retinopathy is also going to increase. Couple of recent pathophysiological advancements have made us understand that we were targeting only one pathway, that was hypoxia driven, but we were not looking at inflammation driven, and entire treatment was centered around the VEGF uptake and its treatment. But a lot of recent interest have been generated in ANG2, that is angiopoietin 2 pathway, interleukin 6 pathway, and ICAM1 as well. So the future therapies are going to be one of the mainstay regarding here, along with VEGF. So this is why we are looking at the treatment for both macro and microvascular complications of diabetes and diabetic retinopathy per se. Patients with diabetes not only have retinopathy, they have other problems like stroke, coronary artery disease, nephropathy, neuropathy, dyslipidemia, and the list goes on. So the important thing here to note is we need to see patient as a whole, and we also need to assess each and every factor like cardiovascular risk factor. If the patient needs any clearance before the treatment, this is very, very important. If you look at a couple of surveys, this was one recently done by American Academy, and they came to know that loss of vision is the most feared complication for any diabetic per se. So it's not only the systemic complications they are worried about, but they are also worried about the loss of vision. So the points here to note at the start of my talk is like diabetes is growing mostly in the working age population, and patients with diabetes are at increased risk of several comorbid chronic conditions, which involve both macro and microvascular complications. And loss of vision is one of the most feared complications for any diabetic patient. Let's look at what happens in the era of diabetic macular edema. Couple of things which have been changed in the management of diabetic macular edema, especially in the last 5 to 7 years. Paramount here to notice, one is nothing but a wide field imaging. We used to see patients with like this on indirect ophthalmoscopy, but we also want to document these patients on a on a wide field imaging to assess. For the first question, the first take home point for everyone today is whenever you see a patient with diabetic macular edema or diabetic retinopathy, first rule out proliferative disease. If you have done that, your half of the job is over, whether the patient has proliferative diabetic retinopathy associated with it or not. because the management dynamics change completely. And believe me, post-COVID era, we are seeing more and more patients with proliferative diabetic retinopathy presenting to us along with macular edema. The second thing you need to rule out is tractional diabetic macular edema. If you have any form of traction which is visually and anatomically significant, this patient needs vitrectomy surgery straight away. There is no point in doing and treating these patients with pharmacotherapy and later on buying some time and then going for vitrectomy. So these patients, the early we subject them to vitreous surgery, the better is both anatomical and functional outcome over a period of time. Seeing patients like this in our OPD, this is an image taken in 2012 by me. But like patient had diabetic macular edema, which is clinically significant, involving the center. But over a period of time, these patients, though right eye, we were in a dilemma at that time whether we want to treat or not to treat. But this type of patients we are seeing more and more commonly in our OPDs, and we are treating them and achieving good anatomical and functional outcome. How we are doing that, we will come to know in a bit. Point last but not the least is not only the wide field imaging, but the wide field angiography also has changed the way we look at these patients. Vascular changes along with OCT angiography. So if you combine this diagnostic tool in your clinical practice, the treatment bias and all those things are negated, and patients are going to get benefited more and more, both on an anatomical and functional outcome. As you can see here, a quite nascent looking retina, but when you do a wide field imaging, you can see so many capillary non-perfusion areas. Unless and until you do a pan-retinal photocoagulation for this patient, treating macular edema for this patient will be really futile. It's not going to benefit him long run. So these are the things we should keep it in mind. So with this backdrop, let's look at a couple of the epidemiological data and start with today's discussion. So as I said, when the diabetic is increasing, as we know, most of the diabetic population across the world have some kind of retinopathy. And when we have some form of retinopathy, we are concerned about VSTDR, that is visual sight threatening diabetic retinopathy, which has to be in the range where you want to treat these patients at an early stage. The DME prevalence is increasing, as well as the microvascular and macrovascular changes are also increasing, which are leading to the vision loss for these patients. We have several risk factors, we know that, but a couple of things just to have a small brush up that we are looking at all HbA1c level. We are also looking at systolic blood pressure, cholesterol, the duration of diabetes, and the drug. Everything has a role, which we'll be discussing in a short while. And the risk for the comorbid conditions as well. We are not looking only at the diabetes and diabetic retinopathy, we are looking patient as a whole. So we need to study the other vascular factors as well, especially if they are concerned with diabetic nephropathy and dyslipidemia. These patients also had a high incidence of cerebrovascular accident and cerebrovascular disease. So we need to have these things also in mind, that the patient whom we are going to treat should be free of any myocardial problems or also cerebral vascular accident problems. Okay, so all these things are quite important. I'm going to skip clinical features of diabetic macular edema for a while right now. We will revisit this slide in couple of minutes. However, we know the clinical manifestations of DME, once they start, they are very difficult to reverse. So before any significant drop in vision occurs, we need to treat these patients accordingly. We need to treat this patient at the early stage. Disease severity scale has also given us the definitions of mild, moderate, severe diabetic macular edema. And over a period of time, a lot of diagnostic tools has helped us how to classify and reclassify these diseases to understand and treat these patients quite, in a methodical way. So we understand that we are dealing with a problem which requires a multifactorial approach, and there are a lot of general constraints both on the administrative side and on the clinical side. So unless and until we collaborate, that means all of us come together, we will not be able to give good functional outcome to our patients. So just to note with a couple of slides which we have seen in the past, is DME occurs in patients who are in working age group, causes a lot of economic burden to the population, and patients with DME are at high risk population patients with a complex comorbidity profile that long-term management. And DME is a common cause of visual impairment in diabetic patients and affects their quality of life. Just look at one anti-VEGF. I have taken only one anti-VEGF for our today's discussion as ranibizumab for two main reasons. Because this was one of the longest, practiced anti-VEGF in clinical settings, and also a lot of biosimilars which are there in the market. They are on the ranibizumab platform. So again, this becomes one of the most commonly used drug in today's scenario. So what is the scientific evidence of using is this drug? The scientific evidence tells us with all randomized controlled trial that if you use this drug as a monthly or even as required basis, it gives you a lot of benefit in terms of functionality and the anatomical restructuring of the retina, and manage these patients quite effectively. It offers beneficial outcomes across patients populations with different ethnicities. This is very important because recent interests have been generated which tells us that the patient with different ethnicities, both diabetics and diabetic retinopathy, they behave differently. And diabetes and diabetic retinopathy is much more commoner in South Indian population, as the data given by Dr. Mohan's group from Mohan's Diabetes Center. So what are the clinical outcomes with ranibizumab? We know that this particular anti-VEGF gives us a lot of functional and anatomical outcomes which are much, much superior than any other treatment modality which is there, which also compares itself with laser, uh, as well as steroid. But the point here to note is this patient needs frequent treatment. That means this has to be really told to the patient at first sitting that you are going to need multiple injections or multiple sessions of treatment. There is no nothing like one stop shop that you take one set of treatment and you are done with the retinopathy or diabetic macular edema. So this is the most important message, that the patient has to be told that you will need treatment frequently and you need to follow with your retinologist or ophthalmologist quite frequently for this. So the other question we had is, why can't we lessen the burden with these patients by adding something? So what can be added with an anti-VEGF? We can add either a steroid or we can add laser. So we have seen that laser does help, the focal macular laser does help, but it doesn't give you any long-term benefit. So anti-VEGF monotherapy, what we call it, that means only anti-VEGF injections, give you a longer duration of action, both for the functionality and the anatomical function, outcome of the for the retina. And laser may or may not be added as and when required. I will be showing you a couple of patients whom we have given laser as well and benefited as well. So is there any value of treat and extend? That means we don't treat this patient monthly. We give them treatment, but follow them monthly and give them retreatment only when it is required on the follow-up visit. Yes, this is a very valuable question. And we have seen over a period of time that the patients who have been kept on treat and extend, that means you can give a treatment every 2 months or every 3 months subsequently when required, have shown a lot of good functional outcome over a period of time and also reduce the patient burden. So just to give a short summary here now, I will be giving you a couple of short summaries in between so that we don't cover everything at the end as take-home points. So we have a lot of trial data available and also the clinical real-world data available, which tells us these patients are kept on treat and extend type of a treatment regime. It gives you much, much more superior effect on the functionality and the longevity of the retina. So how does this scientific evidence which I spoke, that is randomized clinical trials, translate to real world experience? Is there any scientific evidence for this? There is a scientific evidence with different trials. Just take an example of one trial which was Luminous, a landmark study which was conducted over 5 years, a global study which told us that over a period of time, if you keep these patients on treatment on a treat and extend regime, it gives you much more superiority in terms of functional and anatomical outcomes for these patients, and that can be retained over a period of time. So these patients were followed for 5 years, and the functionality and the anatomical changes remained quite significant over a period of time. Another question all of us have whenever we see a patient with diabetic macular edema, whether you want to give anti-VEGF or you want to give a steroid. Lot of points for and against of steroids was there, talk of the town in the past. But what we have the filter down now, steroid, there's definitely kind of a dexamethasone implant. they specifically have proper indications in patients with diabetic macular edema for many reasons. I have just noted down 5 or 6. So one is they give you dual advantage that they act on the inflammation as well as on the anti-VEGF part to a smaller extent. They give you longer duration of action. If it can, the injection can last for 3 to 6 months. The patient doesn't have to get frequent injections. There are certain biomarkers, OCT biomarkers, which we will see in a while. They respond better to steroids. They can be combined with cataract surgery. So another great advantage. They are safer in pregnancy. We are seeing more and more patients with gestational diabetes nowadays, and they are also coming with diabetic retinopathy and diabetic macular edema. So this is safer in pregnancy. It doesn't cross the blood placental barrier. And also in vitrectomized eyes. So many patients are undergoing vitreous surgeries nowadays. This treatment is of a preferred option. So just to note here that we have data from the clinical trials which have translated into clinical practice, and visual acuity were better in patients who receive loading doses of anti-VEGF injections, but then they can be followed up with treat and extend kind of a protocol, and they get a lot of functional and anatomical benefit. So what is the best way forward? And everyone asks, all the postgraduates or the fellows who are there with us, or even the co-consultant, they ask, how are you going to treat this patient with diabetic macular edema? I always tell them that you need to have a custom-made approach. I tell this to my patients as well. Patients will ask 3 injections, 6 injections, 10 injections. What is the answer? I never say any one answer. I said it's a custom-made treatment plan for you. It's a custom-made meal. So how do we take it intravitreal pharmacotherapy? Which one, when, how long, how to proceed further? So let's see the same patient again. When this patient was seen by one of my colleagues, they said, right eye don't treat. Let's treat only the left eye. I said, no, let's treat both the eyes. We will see what happens to this patient in a while. So whatever I'm going to talk, I'm going to tell you with supportive evidence, both for diabetic retinopathy and diabetic macular edema. So if you revisit diabetic retinopathy epidemiology, a lot of clinical trials, a lot of landmark trials like Liverpool diabetic eye study and so on, who told us that we need to treat these patients quite early and quite effectively. Same was told in in Indian from Indian data as well. And I was fortunate to be part of this SN Dream study, which was Sankar Netralaya diabetic retinopathy epidemiology and molecular genetic study, in which we told that we are sitting on a very high burdens of diabetic retinopathy, and we need to treat these patients quite early and quite effectively over a period of time. And this data was studied across 6,000 patients. So it was a very large population-based study done in Chennai and vicinity. And when we told this thing to even the what you call IDF, that is International Diabetic Federation, that around 16 million of patients are having some kind of diabetic retinopathy and the 5 million needs treatment. This was way back in 2013. Now this number has gone to close to 17 million. That means 17 million patients across the globe need some kind of treatment for diabetic macular edema. So it's a huge number. And as we know, the pathogenesis is breakdown of blood retinal barrier, but a lot of recent interests have shifted towards prostaglandins, VEGF, hypoxia driven, and also abnormalities in vitreoretinal interface structures. So we are sitting on a disease which has a complex pathophysiology, both for the retina as well as for the general health. However, the newer insights like inflammation, how does it changes the mechanism of treatment dynamics in diabetic macular edema is also very crucial. We need to know both the pathways, both on the inflammatory side and on the VEGF, and now the Ang2 pathway also, so that we give the optimal treatment for our patients with diabetic macular edema. Nowadays, however, if you just rewind about 12 to 14 years back, there is a group from US called DRCR, Diabetic Retinopathy Clinical Research Trial Group. They again simplified this treatment protocol. Why they wanted to simplify is, it was very confusing whether how you want to grade every patient with CSME, non-CSME, that is center involving diabetic macular edema or clinically significant macular edema. So they said, okay, let's come down to some focus, whether the phobia is involved or not involved on OCT, and also in the clinical examination. If the phobia is involved, let's name it as center involving diabetic macular edema, which is very simple to understand. Phobia is not involved, just call it non-center involving. Then they said whether vision is lost or not. if there is a vision loss, whether the patient is faking or non-faking or pseudo-faking. So these three criteria help you to decide which treatment, where to put these patients, and also try not to confuse with clinically significant macular edema, because this was very observer dependent definition. It was not reproducible with even with the same observer during every visit. So just to recap, phobia is involved or phobia is not involved. If phobia is involved, whether the patient has vision loss or no vision loss. They wanted to give new treatment modalities which can be used in a combination way and also reduce the treatment burdens. So how we investigate patient, a typical patient sitting in our OPD, start from visual acuity, slit lamp examination, gonioscopy wherever required, fundus photography, fundus fluorescein angiography wherever required, and OCT and OCTA are the mainstay of investigation. So this was the older classification of ATDRS. I'm not going to go in detail because we don't use it nowadays. We just use it whether the patient has center involving or non-center involving macular edema. However, you look at OCT very carefully, and then you devise the different subtypes, focal, diffuse, and so on, whether the patient has fractional component, ischemic, or any other associated problems like astroid, proliferative diabetic retinopathy, or has even received some kind of laser in the past and has developed macular edema now. So these subtypes to understand is also equally very important. So DRCR told us simplify and try to reach out to the maximum possible patients. Okay. The purpose of doing all this exercise was to determine if these definitions can be developed that are clinically applicable and reproducible, which is very valid, and variety of associations attached to the terms focal and diffuse DME can be negated. So just a recap, we are just going to see the extent and location of thickening, that is macular edema, involvement of center or not center, quality of the exudates. If you have done fluorescein, what is the source of leakage on the fluoresceins, and how are you going to quantitate this? So I think I have made my points quite simple to understand. Basically, we are looking here is for what is called as optimum response to treatment and also assess the prognosis. So where do we stand with current treatment options for diabetic macular edema? We have variety of treatment agents available with us, right from laser to steroids to anti-VEGF to vitrectomy. This is like micropulse laser. I have personally used this quite a lot, especially in patients with central serous retinopathy and also few patients with diabetic macular edema when they need some kind of a laser for the macular issues. And most often than not, we choose something called as a combination tailor-made therapy. Laser had many advantages, our routine conventional green laser, but the major disadvantage was RP atrophy and sometimes a fibrosis happening at the center of the fovea. So that's where the popularity came down. However, subthreshold micropulse laser, which is a diode laser, has still a role in treating patients with diabetic macular edema, even center involving. We just do this laser on the fovea, but parafoveal, juxtafoveal area, you can safely use this laser. So how we proceed? We see a patient who has macular edema, you decide on the proper investigations, classify them focal or diffuse based on your further OCT classification, see whether the patient still can fit into some category of laser if at all required at some stage, may not be at the primary stage, but at some stage. But the mainstay of treatment is always anti-VEGF or steroid in a minority of population, sometimes a vitrectomy to even start with. So DME classification has changed over a period of time, and OCT has given us different dynamics of this classification. So we are just looking at center involving. In this image, this patient has center involving diabetic macular edema. This patient doesn't have center involving diabetic macular edema. So whether center is involved or center is not involved, imaging, as I said, has changed the way we see these patients over a period of time. But let's look at a couple of simple OCT biomarkers, which will tell you which patient will benefit on the anti-VEGF part and which patient will benefit on the steroid part. So you have focal, increase in the just the central macular thickness. These patients definitely will benefit from anti-VEGF. You have hard exudates. Previously, we used to think only steroid works here, but now we have realized that even anti-VEGF works equally well. You have neurosensory detachment. Definitely, we were thinking in the past that, or even a hyperrefractory dot echoes, that this patient will benefit only from steroid, but it's not the case. This patient can be benefited with anti-VEGF, because anti-VEGF also gives you the advantage of controlling the stage of diabetic retinopathy. So whenever it is not contraindicated, anti-VEGF monotherapy is the treatment of choice for any given patient with diabetic macular edema. However, anti-VEGFs will not work even if you have macular edema along with epiretinal membrane. This patient will need steroids. Hyperreflective dot echoes, though I just said that it will anti-VEGF will work here, but steroid also has a role. But our current understanding has again changed this particular subgroup to anti-VEGF and enlarged deep capillary plexus. That means these kind of ischemic changes over the fovea and around the fovea, if it is there, anti-VEGF may not work. Let's look at the steroids. Definitely, you have neurosensory detachment, as I told you in my previous anti-VEGF choice as well, that you can choose between steroid or anti-VEGF. Definitely, I will personally will choose an anti-VEGF here. Hyperrefractory dot echoes, again, you can choose either way, anti-VEGF or steroid. Definitely, anti-VEGF has a role here. Hard exudates, again, you have a mixed bag where you can choose between anti-VEGF and steroid, but again, anti-VEGF scores here over steroid. However, in certain situations where not, both will not work, will be something like an ellipsoid zone integrated disruption and also external limiting membrane integrated disruption. So these cases, they lie on borderline zone. But again, in these kind of situations, you can still try with treatment and gain some kind of useful vision for these patients, or at least some reduction in metamorphosia. So how do these things guide us of current understanding? So we classify, reclassify, we look at the systemic control of the patients, and we always say, okay, anti-VEGF is one of the first line of treatment, and we can choose our patients accordingly. However, in certain scenarios where anti-VEGF don't work, maybe after 3 or 4 injections, you need to shift these patients to alternative forms of treatment, and OCT and vision and the other key parameters of clinical examinations are must at every visit of the patient. Mostly we are seeing these patients every 4 to 6 weeks in our clinic, and they tend you to give further directions for your treatment protocols. So let's see whether, as I told initially, the steroids, do they have any role in diabetic macular edema? Yes, they do have a role in diabetic macular edema management. Definitely where anti-VEGFs are contraindicated, like recent MI, myocardial infarction, or recent stroke, or maybe chronic kidney disease, where you don't want to give anti-VEGF, and where there seems to be some benefit of steroids or similar benefit to anti-VEGF. So you want to buy time and give less injections to these patients. And anti-VEGF non-responders. So do we have something called anti-VEGF non-responders? Yes, we do have. I will tell you who are anti-VEGF non-responders. And definitely anti-VEGFs to be avoided in pregnancy, recent stroke, recent myocardial infarctions. Vitrectomy is eye, because steroid stays in this eye for longer time and give you much more treatment benefit. And in select cases of treatment naive eyes, where you feel that steroid will score better over anti-VEGF. Like this patient came with a hard exudate. This was one of the clinical trial patients, Beaverdex trial, where the patient had hard exudates, and they have shown that there is a beautiful regression of hard exudates just with intravitreal dexamethasone implant. So these kind of things, when you keep that in mind, you can treat these patients quite effectively. So tachyphylaxis, that means when you have resistance to one type of anti-VEGF, or sometimes the anti-VEGF don't work for these patients. It's much more common in neovascular age-related macular degeneration, as well as a small subset of vascular occlusion patients. But this can also be seen in some what we call as in patients with diabetic macular edema also. So always assess when some point we don't see much of a benefit after giving injections to these patients. So whether look for whether the patient has tachyphylaxis or not, and try to switch over between the class of anti-VEGF or to steroids. So this thing also has to be kept in mind. Before going to the clinical scenarios, let's see what's happening recently in the in the way of further development of diabetic retinopathy, fundus photographs, and so imaging. We are going to see patients having this kind of retinopathy, but the patient will come with a picture itself and tell you, okay, doc, I have this kind of disease at this stage. AI has told me this, and how are you going to treat me? Okay, so it's going to be like a glucometer device, kind of a device. Home OCT already we have seen. So next few years are quite exciting. People have also trying to understand what is happening on the epidemiological aspect, and due to paucity of time, I will be skipping this area. But a lot of developments are happening on the understanding the pathophysiology and the future treatment directions. Our Indian counterparts have also given what is called as consensus-based recommendation for diabetic macular edema. Again, I was fortunate to be part of this landmark, kind of a research from India. And what we have also seen is, if you compare the global trends as compared to American Society of Retina Specialists, we are at par in giving same kind of treatment what has been given in the West. So just try to recap entire talk. You have center involving, non-center involving macular edema. Non-center involving DME, you can still treat with focal laser or even observe these patients. If there is center involving, definitely these patients need anti-VEGF treatment. In pseudophakic patients, you can even consider steroids, even when there is a center involving diabetic macular edema. Center involving diabetic macular edema, along with some other OCT biomarkers, you have variety of options, either anti-VEGF or steroid, but anti-VEGF definitely scores here. In proliferative diabetic retinopathy, definitely anti-VEGF only has to be given. Why? Because it also helps you to control the progression of diabetic retinopathy. Vitrectomy, definitely steroids, along with pregnancy, definitely steroids. Recent severe stroke, definitely steroids. And recalcitrant patients, or maybe vitreomacular traction or taut posterior highlight, these patients need to be taken over vitrectomy surgeries. We are even operating 6, 9, 6, 12, or even sometimes I have operated 6, 6 patients or 6, 6 parts patients. When we see there is a significant traction on the surface of fovea, we don't hesitate in operating these patients quite early. So the same thing which I told you, this was published, yeah, this was from the U-Retina recent guidelines, and this is what we have discussed in my talk so far. So blindness due to diabetes is preventable, and we need to be more proactive looking at everything. However, in Indian scenario, the financial status of our patients also plays a very vital role, and timely intervention is also key in management of these patients. So successful management is not only about injections, not only about laser, not about algorithms. It's a personalized treatment approach for every patient. And you need a very good physician or a diabetologist to back you up for all these treatments. So let's see a couple of cases. Quickly, I'll skip through these cases. So this was the patient had center involving diabetic macular edema in both eyes. We treated with multiple injections, and this patient also, to our surprise, had a central serous retinopathy component here. So this patient definitely needed laser. This is the OCT at presentation, as what you see here. But over a period of time, after 6 months, we get a very clean looking retina. Vision improved from 618 to 66, which you can see there is a reversal of the staging of diabetic retinopathy as well. A very happy and satisfied patient, a gratifying patient, and also with a 100% visual acuity gain. So these kind of treatment approaches are possible. You need to, understand what is happening at the pathophysiological level for this patient. This patient had cataract along with diabetic macular edema, along with tractional retinopathy. This laser was done elsewhere. Normally, we don't recommend to do a laser like this. But over a period of time, if you understand this patient quite well, this patient had some kind of fovea macular traction along with diffuse diabetic macular edema, needs treatment. We did treatment and the patient regained 6 vision over a period of time. Another patient, a ischemic looking eye like this, a chronic kidney disease patient, definitely a not suitable candidate for anti-VEGF, was treated with steroid and did quite well over a period of time. So this kind of macular edemas also can be treated quite effectively with steroids. A clean looking retina with a 6 vision in this eye now, but a favorable anatomical and functional outcome even in right eye over a treatment for 3 years. And this patient did quite well. Still, she follows up with us, and both the eyes are showing stable diabetic retinopathy status over a period of about 10 to 12 years. So very gratifying kind of a patients. These are when you treat them correctly and optimally. So thorough clinical examination and understanding patient needs is also crucial in your decision making. Couple of other cases, this patient had combined retinal detachment due to diabetes in the right eye. No brainer that this patient needs surgery. But when this patient was referred to me for surgery for this eye, I was also interested in treating the patient's other eye. So I considered referring ophthalmologist that just concentrate on the left eye as well. And what you see here with the foveal traction in the left eye, along with some kind of a foveal ischemia. But over a period of time, when you treat these patients bilaterally, this is what you achieve. The right eye did quite well after surgery, but left eye, you see, there is a good reduction of macular edema, almost stable retinopathy status, and a 6/6 vision for last 3 years of follow-up. So these kind of treatment, protocols have to be followed for both eyes when you can salvage the other eye of the patient. This patient was again treated elsewhere with some kind of exudates here, told not to do any treatment, but we was referred for a vitreous hemorrhage, like for a vitrectomy surgery for right eye. But again, we persisted for treatment for both the eyes, and over a period of time, what you see here is a clean looking retina in both left eye when you thought that this cannot be taken care either by anti-VEGF or steroid. But over a period of time, a good anatomical and functional outcome for this patient as well. I will be ending my talk with this patient of mine. Again, this patient is from Dubai. Uh, came to me for a second opinion. I told her you just need a pan-retinal photocoagulation, avoiding this traction area, and see the visual acuity at presentation 6/6, that is 20/20 vision. The patient was supposed to fly back to Dubai for some other reasons, and she opted to get treatment done there. I'm not against any treating physician, but what they did was they also instead of doing only PRP, they did a PRP, but they also added anti-VEGF and cataract surgery. So now what you add anti-VEGF when you have an active proliferation or a traction, that is, this is active proliferation and traction, you get something called as an angiofibrotic switch. Same thing happened to this patient. When she presented to us, fovea was absolutely normal. But what you see here after the anti-VEGF, 3 weeks later, she flew back. She said, my vision has dropped from 2020 to 2080. Now what you see is a foveal traction here, which has increased because of the fibrotic component of anti-VEGF. So you need to be careful as also when we are going to inject, what drug you are going to inject, and at what stage of retinopathy you are. To my surprise, by the time I took her fitness for surgery, she also developed something called as a de-roofing of fovea. The fovea here has been split, okay, because of this traction. The traction was pulling on the fovea, but still we persisted with vitrectomy. We operated her, and what you see here, we were we were almost able to restore the foveal contour after the surgery. And over a period of time, in spite of having a foveal de-roofing, what you see here, though the vision remained only at 20/30, that is 6/9, but she regained foveal contour, which was quite good anatomical and functionally. So these kind of judgments are also very important as one we are going to treat these patients. If at all you are planning laser or anti-VEGF or steroid injection or vitrectomy, the decision making is the most important aspect, and also at the same time you need to educate these patients as well accordingly. So to wrap up my talk, we are here to treat these patients as an overall with a quite holistic approach, explaining the prognosis and improving their visual outcomes. Thank you so very much for your patient hearing. I'm sorry I've been overshoot by about 10 minutes or so, but the topic given to me was quite broad, and still we have a lot of a lot of points to discuss and debate. Thank you
Well,
so much.
thank you, Dr. Manoj, for such an eloquent and comprehensive talk on diabetic macular edema, where you explained how to diagnose and then how to treat, which modality to use, and what are the pointers which suggest which modality like steroid or anti-VEGF or laser will be needed. So thank you very much for this talk. Let me also introduce our panelist for today, Dr. Sunil Ganekal. Dr. Sunil has joined us in the program. Dr. Sunil did his retina fellowship from Shankarnatralaya and New York Eye and Ear Infirmary. He also did his ocular oncology fellowship from New York under Dr. Paul Finger, and he was trained in cornea at Pinto Hospital, associate with Mayo Clinic, USA. So welcome, Dr. Sunil, again.
Hi, Kumar.
Hi. So, Dr. Khatri, I would like to ask first question which we have for the day is, what are the cases where will you suggest laser, focal laser, straight away at the first onset? I mean, treatment naive eyes where you will suggest laser.
When you have a lot of leaking microaneurysms, by any chance, if you have done angiogram, for these patients, and definitely focal laser I still do. And we have access to substantial micropulse laser as well, as I told you, so we do prefer that. And the another aspect where definitely you're having a patient who has, cost constraints. So may not will require many injections, but they can't afford. So definitely in those subset again, laser still has a role.
One more indication for laser probably I would have think of is anybody has got a refractory diabetic macular edema who has got a multiple injections, kindly do an angiography. You have to rule out a condition known as telcaps or retinal telangiectasia. How they do differ from microaneurysms is usually microaneurysm size is around 30 microns. These will be in the range of around 200 microns. They will be adjusted to the area of edema. In these patients, unless you do laser to these cell caps, no way they are going to respond to these anti-VEGF injections. That is one of newer indications for laser one should consider, especially in refractive DMEs. Please kindly rule out tel caps. These tel caps can be seen clinically also, but on angiographically, you can highlight them much better. On an OCT, they typically have an hyperreflective covering. They looks like typically like something which look similar to outer retinal tubulations. In these patients, typically you will have an intraretinal fluid, multiple injections would have been given, they never respond to anti-VEGFs. So please rule out telcaps or retinal telangiectasias in these patients, especially those who are refractory to diabetic macular edema. We always keep on switching from one anti-VEGF to another anti-VEGF. So these patients, please consider laser as a focal laser is another option.
So, but can we see these del caps on OCT angio also, Dr. Sunil?
Yeah, unlikely because the OCT, structural OCT and FA picks up better than the octa in these patients. So telcaps is definitely has to be ruled out, especially you tend to see them in chronic DMEs and those with a longer duration of diabetics. But definitely they respond very good to even a single session of a focal laser treatment.
Okay, great. So as we were seeing a lot of cases with large hard exudates amounts which were treated and successfully the hard exudates amounts reduced over a period of time with improvement in vision. So there is a question regarding sarcinate maculopathy. So with exudates over the fovea like plaque. So what is the best treatment of choice in such scenarios? A question to both of you. Dr.
Yeah.
Manoj.
Definitely, I'll prefer anti-VEGF monotherapy for these patients, because with newer anti-VEGFs, tough hard exudate plaques also can be well treated with anti-VEGF monotherapy. In some situations, you can even top them up with steroid as and when required. So Ozurdex can be added at some stage.
The only concern would be if you've got somebody who's got a perifoveal hard exudates, is a subfoveal migration of hard exudates. So
Yeah.
probably in such scenarios with good vision, one should be very skeptical in treating with anti-VEGF. So vision is also a criteria apart from the hard exudates associated with DME.
So maybe we can divide it into subfoveal hard exudates which are already there, and a
Yeah,
case
yeah, yeah,
phobia is still spared, peripheral
yeah,
hard exudates are there.
yeah,
So
it's
in
true.
those scenarios, maybe we can avoid anti-VEGF. What's your take?
Probably vision is good. The perifoveal hard exudates, not much thickening. It's a subclinical edema. One can wait. But if you sold, there's a subfoveal hard exudate says probably if it is a plaque, probably and steroids as Manoj told, probably if it is a focal hard exudates, probably anti-VEGFs can be considered.
Okay, great. So we have a question regarding role of oral anti-diabetic medication in management of diabetic retinopathy.
Yeah, the studies have shown that thiaglitazones probably will have a impact on the DME and they may increase the risk of diabetic macular edema, especially high-risk patients who are associated with chronic kidney disease and other things. So thiaglitazone, if there is a chronic history of duration of treatment with thiaglitazones, one need to look into and ask an opinion from physician whether they can be switched over to other oral anti-diabetics or anything of that sort.
Okay. And regarding tachyphylaxis, what are your treatment of choices? Like, do you start with ranibizumab or other anti-VEGFs or aflibercept? When do you decide, or how do you decide, Dr. Manoj? When you start a treatment and
If
treatment diagram?
yeah, you take a treatment naive or even a patient who have been treated already somewhere and come to you for a second opinion. If cost is not a problem, definitely treatment of choice is aflibercept as of now. I've even treated a couple of patients with faricimab and brolucizumab for diabetic macular edema. In fact, the case which I showed you, the last couple of cases where the surgery was done for the other eye, those patients have been treated with brolucizumab or faricimab. So definitely they give you much better advantage of getting the structural integrity as well as reducing the number of injections over a period of time. So and faster resolution of diabetic macular edema. So we need to pick and choose. The drug to go right now is somewhere in and around aflibercept, but definitely usage of ranibizumab has not come down. More so the biosimilars when they have come in the market. So the usage is quite extensive on that platform as well. So always custom made. There is no one drug which you are going to prefer over other like that.
Probably studies show that since bevacizumab being an off-label, ranibizumab or aflibercept are the preferred choice. But if somebody has got a poor presenting visual acuity, if you compare head-to-head with bevacizumab with ranibizumab, probably patients with poor presenting visual acuity may benefit with bevacizumab more than the ranibizumab. But on a long term, both does the same. But if you're looking at a short term, probably those who have got a poor best correcting visual acuity on presentation probably may respond to bevacizumab better than the ranibizumab. But the only concern is being the safety issues and the off-label nature of the drug.
Okay, right. So, do you feel that tachyphylaxis is a real life problem in treatment of diabetic macular edema when treating with
Very small
anti-VEGFs?
subset of patients. Very small subset of patients. Very small subset.
Yeah. So as
Unlike
well,
AMD, not much with the DME patients, I think. I feel.
okay. And while on the course of treatment, when do you decide to switch between anti-VEGFs, or you directly switch from anti-VEGF to steroid? So what is the take on this?
Let wise counsel answer on your part, KS. You should answer this question for us.
No, I'm the one asking the questions today.
But what is your opinion on this?
Yeah, I mean, as both of you are rightly mentioning that aflibercept is the treatment of choice. If not, then ranibizumab. So I switch from ranibizumab to aflibercept, but not other way around. And if aflibercept is not worsening, probably I repeat the fluorescein angiography and then shift to anti-VEGF, or there is conversion of PDR. So all these things come into picture. So these only two anti-VEGFs. Yeah, that's it.
Totally agree with you. So same thing in here also. Definitely the threshold for treating with higher anti-VEGFs is much higher nowadays. So we are prescribing more and more on the lines of faricimab, brolucizumab, aflibercept. Initially, we were very hesitant, all of us, I'm sure, that let's stick to only bevacizumab or ranibizumab. But now most of us have shifted, the trend towards higher anti-VEGF, and it's quite effective as well. So if you see the long-term data or long-term clinical practice scenarios, the number of injections have come down. The functional and anatomical outcome also are much superior than longer acting anti-VEGFs.
Yeah. And how has the experience been with faricimab for the recalcitrant DME cases? A question to you.
Uh, Quite good actually. I have not treated as of now. I have treated only one patient with recalcitrant TME for with faricimab. A patient is yet to receive his third injection. Only 2 injections are over. But I have treated a lot of treatment-naive patients with faricimab, almost 4 to 5 of them, and they showed very good response. The only hitch still remains with faricimab is that loading dose concept, which we are not able to still come up in line. Whereas the loading dose concept is not there with brolucizumab, and to some extent with aflibercept as well. So there you have to pick and choose which patient you are going to put where. So if loading dose is not a problem, definitely faricimab scores. But most often or not, these patients are quite benefited with brolucizumab. So I'm quite distinct towards brolucizumab. Whenever you see a patient with recalcitrant DME or recalcitrant CNVM or IPCV, those kind of things, shift towards brolucizumab than faricimab as of now.
Okay. And you showed an interesting case where there was a large heart exudate mound, and then there was probably preretinal or subretinal hemorrhage, CNVM, combined with diabetic macular edema. So how did you treat this case, and which injection was given, and
This
what
was
would
in
you?
the era of only ranibizumab available. This was in 2013, 2014. Only ranibizumab was available and bevacizumab, so we were not using that.
Mhm.
But the patient, The beauty about if you get any complication like CNVM or anything in diabetic macular edema, they just need 1 or 2 injections. The CNVM responds quite effectively to just 1 or 2 injections. Doesn't go beyond that. I had about 4 or 5 patients who developed CNVM over a period of time, and they needed only 1 or 2 injections.
Okay.
And one more thing regarding the imaging biomarkers we thought about. Question to Manoj, if you want to look at the one biomarker for a prognostic, which one will you choose? One biomarker.
Hyperreflective dot impulse.
I think probably I will consider drill more than an hyperreflective foci for the prognostic point of view.
Yeah, but drill, the subset is very less. No? Drill, you don't get much of drill now. Definitely drill has a poor prognosis. All of us know that.
Hyperreflective foci, there will be so many coexisting pathologies with diabetics. So you tend to see hyperreflective foci in those pathologies also. So mainly thing is hyperreflective foci may help in treatment decision, but the prognosis and the visual point of view, probably drill is a better indicator than a hyperreflective foci.
Okay. So what about the large cystic spaces which happen right at the fovea? If you have CME, chronic CME with large cystic spaces, these are more of a kind of a degenerative changes. So do you shift towards steroids in such cases or continue with anti-VEGF? Just large cyst at the bang at the fovea.
The problem is switch over to steroids, and probably combination therapies works better in these cases rather than a monotherapy as such. And probably you may have to add a focal laser if you can find on an angio some leaks or other things that would help also in resolving the cystoid spaces.
Okay, Dr. Manoj, your take on this?
Yeah, either way you can go ahead. See, the chronic cystoid spaces we have seen again. Brolucizumab is one of the drug of choice here. It works quite well with that. And in select cases where you see that the edema, though very rare, is not responding, then you can even club treatment, like maybe give steroid or anti-VEGF first, and after a few weeks steroids, or give steroid and after sometimes repeat anti-VEGF again. These are all very rare cases, but you need to pick and choose where you are going to inject what.
Okay, so we have an interesting case. It goes like in DME with traction, is it possible to do an anti-VEGF injection prior to vitrectomy in the setting where the vitrectomy is not readily accessible? DME with traction, is it possible to do anti-VEGF injection prior to vitrectomy in the setting where
Definitely.
vitrectomy is not readily available?
Yeah, very good question. First of all, whenever you're planning any anti-VEGF prior to vitrectomy, whether it is for vitreous hemorrhage or anything else, first get a physical fitness first for the surgery. Very, very important. We have seen few patients in the past that you have injected and the patient has not got fitness for the surgery for some other reason, and then you land up in a mess. The proliferative, as I showed, one of the patient, though patient had fitness, but it can go either ways. The second thing is that you should be very sure what is the indication for injection in any patient who has traction. So when you're deciding on operating, go ahead, no problem. But when you're deciding against surgery or you just want to buy time, then definitely no injections, especially no anti-VEGFs. So this is the second point to be kept in mind. And also when you're planning for surgery, these patients have to be operated within a window of 3 to 7 days. You can't go beyond that. So these are just a couple of pointers you keep in mind, and you can safely inject. There is no problem with not injecting. But again, if you have follow the protocol, that means getting the fitness, knowing the indication, and scheduling the surgery accordingly.
Probably one thing could be if you don't have an access to vitrectomy, the only probably I would consider in focal VMTs are better to inject. If you got a diffuse VMT and probably will not respond to anti-VEGF surgery, you need to refer the patient rather than. But focal VMTs, definitely you can give a trial of anti-VEGFs.
Okay. Dr. Sunil, what is your take on loading dose of faricimab in DME?
Usually, I don't go by I go by the treat and extended regimen. I stop giving loading doses unless it is a poor compliant patient who cannot come back and other things. Probably in such scenarios or exceptional cases, you can consider loading doses. Otherwise, as Manoj told, treat and extended regimen is a better accepted thing than looking at the loading doses.
Great.
The other thing with faricimab is you don't get an immediate wow effect. So this also we need to keep it in mind. If you are seeing this patient in a week or two, and you most of the structural changes on OCT remains the same, and patient doesn't appreciate much. Only after a couple of injections only they are able to appreciate. So it's not that wow effect which we get with aflibercept or brolucizumab.
Okay. And finally, a very important question that we usually get from our nephrologist friends, that the nephrological status or renal status of the patients gets hampered by anti-VEGFs. So what do you do in such scenario? Do you have any set point that above this creatinine level you ask for a nephrologist clearance, or you take a history about renal issues? What do you do?
Saurabh, I think you remember that we shared in a research meeting, we discussed this thing in a chronic kidney disease, anti-VEGF doesn't alter the creatinine levels or any other things. Probably it's not an absolute contraindication, it is a relative contraindication, unlike cardiac problems and other things and all. Even GFR or creatinine are unaffected by chronic anti-VEGF therapy. So it's not such an absolute contraindication for in a chronic kidney disease patient. So you can go ahead and treat it, unlike a patient with a cardiac problem, acute cardiac problem.
Yeah, the issue happens when the nephrologist comes back and tells the thing that since your renal anti-VEGF has been given, so your renal parameters are deranged now. So that happens sometimes in practice.
But studies have shown that it doesn't affect either of these, either the GFR or the creatinine levels.
So in your practice, you are not very much going on any particular level of renal.
No, not with the chronic kidney disease, but of course with the cardiac patients.
Okay. Dr. Manoj, your take on this?
Definitely, I don't cross lines with the nephrologists. If they say it's contraindicated, definitely, because there is a very fine balance between our, argument and their argument. Whenever required, I don't hesitate to get a renal clearance. That is point number one. The second thing is that we have still steroid as an option to treat here. It's not like a CNVM where you don't have any other option. So definitely we balance between anti-VEGF and steroid and then take it forward. Though I'm yet to see any patient who received anti-VEGF and developed some kind of a, exacerbation of renal or derangement of the renal parameters. But especially in the area where we practice, nephrologists are very reluctant to give fitness for anti-VEGFs for some reason or the other. Especially in Chennai, they are very reluctant. So you need to strike a balance here. If you
Yes.
give a letter to them, if you don't give a letter and just go on your treatment and there is no, point has been raised. But if you ask for fitness, very difficult to get fitness from them.
Yeah. So what we understand is that there is no cutoff level or something. We have to decide.
Nothing published or documented.
Yeah, exactly. So it was a great session, 1 hour.
On similar note, can I add just one point?
Yeah, please.
Last week, the Indian Nephrology Conference have shown one very interesting presentation on OCT parameters for renal disease. So what they are trying to really, because OCT is a non-invasive test, what they are trying to highlight or drive a point is get an OCT and see their GFR based on the on the choroidal status and also the retinal status. It's a long publication. I cannot share it right now here, but nephrologists are relying on retinologists or ophthalmologists now to understand the structural and the functional changes happening in the retina and trying to modify their treatment as well on the kidney part as well. So the future is going to change.
Yeah, exactly. So we have covered most of the questions in the chat box, and yes, thank you, Dr. Manoj, for an excellent presentation, and Dr. Sunil for being there and helping us with the webinar. Dr. Preethi, that's all for the day.
Yeah, thank you so much, Dr. Saurabh, for the wonderful moderation. Thanks, Dr. Manoj, for the great presentation, and thanks, Dr. Sunil, for the valuable inputs. Really very informative lecture, and I think it will be useful for anybody who watches this even online later on as a recorded version. So you may please conclude, Dr. Saurabh.
Yeah, thank you, Dr. Everybody.
Thank you so much, everyone. Thank you so much.
Thank you so much.